Vanakkam. Normally, the thumb has only two phalanges and a metacarpal. But when there are three phalanges, there are a few questions that we need to ask. Will we call it a triphalangeal thumb or should we call it a five-fingered hand? Is it a thumb that has got three phalanges or is it just another finger and no thumb? And the next question is, so what if there is an extra phalanx? It is good, it is going to be long enough. Isn't it? Not at all. There are a lot of problems that can come with it. It is not only an extra phalanx that is there is an extra interphalangeal joint also that forms. So how do we manage this? Can we just remove that extra phalanx? And if we do so, will the thumb be stable enough? All these questions and more answered in this video on the triphalangeal thumb and the five-fingered hand. Normally, there are two phalanges, the proximal phalanx and terminal phalanx and a metacarpal in the thumb. But sometimes there are three phalanges in the thumb along with the metacarpal. In that case, it could either be a triphalangeal thumb or a five-fingered hand. In this video, we shall see more about these two entities, the triphalangeal thumb being the more important. At the outset, let us get it very clear. The extra phalanx of variable size within a relatively normal appearing thumb is known as a triphalangeal thumb. The extra phalanx may be delta shaped, trapezoidal or rectangular in shape. A fully developed phalanx that lies in the plane of the fingers is known as five-fingered hand. This could also be considered a total hypoplasia of the thumb with index polydactyly. The triphalangeal thumb, that is, a thumb with three phalanges, was first reported by Colombo in 1559 and later by Dubois in 1826. This triphalangeal thumb has an incidence of 1 in 25,000 live births, and of all patients with a triphalangeal thumb, which is otherwise known as TPT, 2/3 have a family history of bilateral thumb abnormalities. Triphalangeal thumb can be inherited as an autosomal dominant trait. Sporadic cases are mostly unilateral and supposed to be opposable, so they have better function. Let us now see the different ways in which this triphalangeal thumb can present and the different features that are present. The most important feature, of course, is the extra middle phalanx that is present. The shape of this extra phalanx can vary from a very small wedge-shaped extra phalanx resulting in a deviation at the interphalangeal joint to a fully developed extra phalanx resulting in a long thumb. Other features can be a near normal to a very hypoplastic thenar musculature, a near normal to contracted and less deep first web, and an extra finger or ray which could be partial or fully developed. The thumb may be in the same plane as the other fingers with a finger-like appearance, and here it is known as five-fingered hand. Normally, a thumb has only one interphalangeal joint, but here in the triphalangeal thumb, there are two interphalangeal joints, the proximal interphalangeal joint and the distal interphalangeal joint. Both interphalangeal joints may be mobile, or one may be mobile, one may be stiff. Even when the middle phalanx is trapezoidal or rectangular, often active movement is possible at both joints. The metacarpophalangeal joint can be stable to very unstable. Hyperextension at this joint is common. The carpometacarpal joint of the thumb can vary from hypoplastic to malformed, resulting in variations from a less mobile to an unstable joint. The carpometacarpal joint can also be absent. Also, the trapezium and scaphoid can be hypoplastic, malformed, or even absent. We have already seen that in inherited cases, this condition usually presents bilaterally. If an extra ray is present, usually the ulnar side thumb is better developed. It may be associated with other malformations like syndactyly, ulnar polydactyly, or cleft hand commonly. Generally, triphalangeal thumbs are non-opposable, except perhaps the unilateral variety which presents sporadically. Since there are so many different types of presentation of the triphalangeal thumb, it is important to have a clear understanding of the classification. There are three main classification systems. The Woods classification is based on the shape of the extra phalanx. The Buck-Gramco classification is based on the shape of the extra phalanx and the associated malformations. The Wassell's classification classifies the triphalangeal thumb when it is associated with duplication. When the extra phalanx is delta shaped or triangular roughly, it is classified as type 1 Woods classification. When the extra middle phalanx is either rectangular or trapezoidal in shape, it is classified as type 2 under Woods classification. And when the shape of the extra middle phalanx is full, it is classified under type 3. The Buck-Gramco classification takes into account the shape and also associated malformations. In type 1, there is a delta-shaped extra phalanx along with rudimentary triphalangism. In type 2, there is a short triangular middle phalanx. In type 3, it is a trapezoidal middle phalanx. And in type 4, the middle phalanx is long rectangular. Type 5 of the Buck-Gramco classification of the triphalangeal thumb has the features of hypoplastic triphalangeal thumb, and type 6 is triphalangeal thumb associated with polydactyly. Triphalangeal thumb can very commonly be associated with duplication. In such a situation, it is classified by the Wassell system, where type A refers to a duplicated thumb at the level of the metacarpal with a triphalangeal ulnar thumb. Type B is a duplicated thumb at the level of the metacarpal in which both duplicated thumbs are triphalangeal. Type C is a duplicated thumb at the level of the metacarpal again with a triphalangeal radial thumb. And type D refers to a triplicated thumb in which the central component is triphalangeal. Triphalangeal thumb can be an isolated anomaly or it can occur concurrent with thumb duplication. We have already seen Wassell type 7. You can click on the link above to see more about the thumb duplication. It may be associated with a syndrome or it can occur with other congenital malformations. The commonest associated syndromes are the Holt-Oram syndrome, the ACE syndrome, the Diamond-Blackfan anemia, and Townes-Brocks syndrome. The common malformations associated with triphalangeal thumb are radial polydactyly, syndactyly, and claw-like hand or foot. The picture alongside shows a triphalangeal thumb associated with a cleft hand. We have seen the features and the presentation of the triphalangeal thumb. Let us now try to understand the management of this condition. To start off, we need to first answer one question. Is surgery necessary? And the answer is yes. Surgery is necessary if there is deviation of the thumb, excessive length of the thumb, restricted function and movements in the thumb, or aesthetic concerns. The goals of surgical treatment are to reduce the length of the thumb, to create a good functioning, stable and non-deviated joint, and of course, improve the appearance of the thumb. The timing of the surgical management of triphalangeal thumb depends on a few factors. For wedge-shaped phalanges and in radial polydactyly, surgery is ideally done at the age of 1 year. In the case of 5-fingered hand or longer triphalangeal thumbs with only slight distal deviation, there is no need for an early operation. The only idea is that surgery must be finished with both hands before the children go to school. Surgical management of triphalangeal thumb consists of management of the individual components or the individual problems that occur in this condition. And here there are 6 important points to be noted. The first is the extra phalanx, which leads to increased length and angulation of the growing thumb. The second problem is the extra interphalangeal joint that is present. The third problem is the first metacarpal itself. The fourth problem is the thumb index web space. The fifth problem is the absence of thumb opposition, and the final problem is the concomitant anomalies or malformations that may coexist. Let us consider all these one by one and try to understand how each problem can be corrected. The first problem to tackle is the most important: the increased length and the angulation of the growing triphalangeal thumb, and this is basically due to the extra phalanx that is present. As we have seen, it can present in various shapes and it has an unpredictable natural history. If the extra bone is rudimentary with very little growth, no treatment is needed. But if the extra bone has continual or asymmetric growth, it will lead to excessive length or progressive angulation respectively, and this should definitely be treated. The options available for management of this are excision of the extra phalanx, and ligament reconstruction as described by Buck-Gramco, or osteotomies with resection of the distal interphalangeal joint or proximal interphalangeal joint followed by arthrodesis. And let us now consider each of these in detail. The excision of the extra phalanx can be done up to 3 years of age, but it runs the risk of angulated joint with growth. Along with the excision of the extra phalanx, ligament reconstruction needs to be done to provide stability to the remaining thumb. This can be done by two techniques. If there is minimal angulation, repair of the ligaments can be done. If there is severe angulation, lengthening of the ligaments can be done. In the first method, by a dorsal approach through the extensors, the bone is dissected out with osteoperiosteal sleeves elevated along with the attachment of the collateral ligaments. The bone is removed and the collaterals are reattached to the remaining bone. A K-wire is applied with a long thumb spica cast. In the second method, if it is a severe angulation and there is a skin surplus, it is excised on the convex side and a Z-plasty performed on the contracted side. The collateral ligament is reconstructed by releasing it to a V to Y fashion on the contracted side so that it can lengthen, and shortening it on the non-contracted side. If the deviation is only slight, a release on the contracted side is enough. This is a clinical example showing the results of this procedure. This procedure has been termed the delta phalanx excision and ligament reconstruction by Hovius et al. In 2019. There is an extra interphalangeal joint in the triphalangeal thumb. An extra interphalangeal joint has a variable amount of motion. The extra joint is actually of little consequence with regard to function. A large wedge-shaped extra phalanx can produce excessive length with or without deviation. Excision of the phalanx should not be performed because subsequent instability is common. Fusion of the abnormal phalanx with the distal or proximal phalanx combined with bone shortening removes the extra joint, realigns the thumb and corrects the length. The joint with the greatest motion is preserved and the joint with the least motion is fused. This is among the proximal interphalangeal and distal interphalangeal joints. This procedure is usually advocated in older children, that is more than 3 years old, or those who have a very large extra phalanx. Among the DIP and PIP joints, the DIP joint is more asymmetric. So the procedure done is excision of the DIP joint and reduction osteotomy about 1 cm at the distal part of the middle phalanx and arthrodesis. So this is the segment of the joint and the bone, that is the distal portion of the middle phalanx, which is removed in this procedure. The same can be done for the PIP joint also. This will achieve a good alignment and stability. Here, excision of the PIP joint plus reduction osteotomy of about 1 cm at the proximal part of the middle phalanx along with arthrodesis to yield a stable and longitudinally aligned thumb. Since this procedure usually involves the distal interphalangeal joint, it is called the distal interphalangeal reduction arthrodesis procedure. This clinical picture shows the results of DIP joint arthrodesis after reduction osteotomy, and this picture shows results after PIP joint arthrodesis after reduction osteotomy. So far, we have been concentrating on the extra phalanx, the proximal interphalangeal joint, the distal interphalangeal joints. The first metacarpal bone also has a role to play in the triphalangeal thumb biomechanics. The normal first metacarpal has a growth plate at the proximal end of the metacarpal. In patients with triphalangeal thumb, the first metacarpal can have a proximal, distal or proximal and distal growth plates. So a study was conducted in 37 patients with 59 affected hands in 2019 by Hovius et al. The findings were as follows. All first metacarpals in patients with triphalangeal thumb were longer than normal. If there was a proximal growth plate, the length of the first metacarpal was normal. The distal growth plates were found to be more in triphalangeal thumb patients, and most of them had a full extra phalanx. And finally, the first metacarpal became longer than normal if there was a trapezoidal or full extra phalanx. Two important inferences were made as a result of the findings that we have seen. The first is, if the thumb is not too long, resection of the wedge-shaped extra phalanx, that is the DEL procedure, or reduction arthrodesis at the DIP joint level will be enough. If the thumb is long, in the case of a trapezoidal or full extra phalanx, shortening at the metacarpal level also is needed. So this means that a distal interphalangeal joint reduction arthrodesis is done along with the shortening osteotomy with rotation and abduction at the metacarpal level. This helps in gaining more opposition position of the thumb. This procedure was called the rotation shortening osteotomy with abduction at metacarpal level. This shows the first metacarpal with a duplication, and an osteotomy is done on the shaft of the metacarpal and a segment of bone is removed. The distal portion of the metacarpal is then rotated so that it achieves an opposition position. The next important problem in the triphalangeal thumb is the involvement of the thumb index finger web space. A narrow web space hampers thumb function. We all know this. But if it is a mild thumb index finger syndactyly, it can be managed by web deepening by 4-flap Z-plasty. If it is a moderate thumb index finger syndactyly, local dorsal rotation flap needs to be done for adequate deepening and widening of the thumb web. If there is a severe thumb index finger syndactyly, as in 5-fingered hand where there is almost no web space, it will have to be dealt with in a different manner, which we shall see when dealing with the management of the 5-fingered hand. Opposition obviously is very important for function of the thumb. The absence of thumb opposition occurs in some cases of triphalangeal thumb and commonly in the 5-fingered hand. Since opposition is needed for function, muscle transfers, either the abductor digitae minimi transfer or the Huber transfer or the flexor digitorum superficialis transfer from the ring finger can be done to achieve opposition. The final problem is the concomitant anomalies or malformations. A triphalangeal thumb combined with thumb duplication is treated according to the principles of thumb reconstruction. That is, the dominant component is preserved and the non-dominant part is deleted. If the triphalangeal component is dominant and is preserved, treatment of the extra phalanx should be done either in the same stage or later. But preserving the triphalangeal component will mean that more surgical procedures are required to get back function. To avoid this problem, Wassel and Wood advised excision of the triphalangeal thumb component even when the other biphalangeal thumb was more rudimentary, because they wanted to avoid the need for repetitive surgeries which would be required if the triphalangeal thumb was preserved. On the other hand, Upton and Shane advised preservation and correction of the triphalangeal thumb part and excision of the rudimentary biphalangeal thumb, because they felt that a stronger thumb was needed even if it required more surgical procedures. As we have seen, the triphalangeal thumb can be combined with central deficiency. This can be treated by combining the principles of cleft and triphalangeal thumb reconstruction. You can click on the link above to see the principles of management of cleft hand. Complications after triphalangeal thumb surgery can occur. Unpredictable growth of the thumb, especially of the first metacarpal after the initial shortening, can occur and result in longer thumbs than intended. Skin problems, infection and malunion or non-union are very rare. Arthrodesis of the distal interphalangeal joint can give a nail deformity also. As with all surgical procedures for congenital differences in the hand, secondary procedures may be needed. For instance, opposition transfer may be needed to improve the opposition strength. We also may need to do thumb length corrections using epiphysiodesis or shortening osteotomies when the growth has stopped. For conditions like hypermobile metacarpophalangeal joints, volar plate tightening procedures may also be required. We have seen a little about the five-fingered hand in the course of this video. Let us see a little more about it and the management options. The five-fingered hand is always longer than the triphalangeal thumb because it has a fully developed extra phalanx. It lies in the plane of the palm. The extra phalanx is normal shape and size of the middle phalanx, and extrinsic and intrinsic muscle anatomy mimics a finger more than the thumb. Management of the five-fingered hand depends on whether the procedure is done in early childhood or late childhood. In early childhood, policization of the radialmost digit needs to be done. But there are two important points to be noted here. Rebalancing of the intrinsic musculature is paramount to the success of the procedure. In the five-fingered hand anomaly, the dorsal introsseous to the radial digit is only unipennate, and secondary opponentsplasty with either abductor digiti minimi or the ring finger flexor digitorum superficialis transfer is necessary. And the most important procedure is the creation of a broad first web space with unscarred flap tissue. In late childhood or adulthood, the management of the five-fingered hand is different. Policization is not a very preferred procedure in later age. There are two important options regarding the management. First is construction of a first web space with a forearm flap and arthrodesis of the proximal interphalangeal joint. The second important option is rotational recession osteotomy of the first metacarpal with policization and intrinsic rebalancing. This clinical picture shows a five-fingered hand for which a radial artery forearm flap has been done for resurfacing the thumb web and a PIP joint arthrodesis has been done. To summarize the different options of management and the indications, let us correlate these different methods with the Buck-Gramco classification. In type 1, where there is rudimentary triphalangism, and type 2, where there is a short triangular middle phalanx, removing the extra phalanx and performing a ligament reconstruction will produce a functioning thumb. In type 3, where there is a trapezoidal middle phalanx, if the patient is less than 6 years, the removal of the extra phalanx and ligament reconstruction can be done. But if the patient is more than 6 years of age, ligament VY-plasty and DIP arthrodesis is preferred. In type 4, where there is a long rectangular middle phalanx, reduction osteotomy of the middle phalanx along with distal interphalangeal joint arthrodesis and rotation osteotomy of the first metacarpal is indicated. In type 5, which is a hypoplastic triphalangeal thumb, policization or rotation osteotomy of the first metacarpal is advised depending on the age of the patient. In type 6 triphalangeal thumb, according to the Buck-Gramco classification, it is a triphalangeal thumb associated with polydactyly. Removal of the hypoplastic thumb and management of the triphalangeal thumb is in order. I hope you enjoyed the video. I enjoyed making it. Please do click on the shown links to see more about the hypoplastic thumb and its management. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics.